Hi all. Greetings from Department of Neonatology, ICRA Hospital, Calicut. I'm Dr. Rahul Illaparambath, neonatal consultant at ICRA Hospital. First of all, a big thanks to NNF Kerala and NNF Pathanamthitta for giving us this opportunity, big platform for nurses for continuing nursing education. Coming to the topic, the first part of our topic has been discussed by Dr. Shabir. It is about the care of an asphyxiated newborn. Hope you all might have gone through the first part. I'll be dealing with the second part, that is care of a newborn who is undergoing therapeutic hypothermia. So I'll just share the slides here. So coming to my topic, it is a care of a newborn undergoing therapeutic hypothermia. This topic is relatively new for at least some of you because these interventions are mostly done in tertiary care centers. So you just can go through the slides and we can have a discussion at the end of this session. Now, a couple of slides which is discussing certain terminologies. I think it has already been covered in the first part. So perinatal asphyxia, it is an impaired gas exchange in the fetus that is leading to combined hypoxemia, hypercarbia, and fetal acidosis. So perinatal asphyxia, it results in modes, that is multi-organ dysfunction syndrome. This perinatal asphyxia can affect brain, heart, kidney, lungs, liver, intestine, bone marrow, etc. So the cause can be multifactorial. It can be from related to the mother, can be related to the fetus, as well as any impairment in the uteroplacental flow. Hypoxia, it's a partial lack of oxygen in the blood, and anoxia is almost complete lack of oxygen in the blood. And ischemia is a reduction or cessation of blood flow to an organ. Now, hypoxic ischemic encephalopathy, it's an abnormal neurological behavior resulting from a perinatal hypoxic ischemia. So it results in neurodevelopmental impairment in the form of neonatal seizures, encephalopathy, then cerebral palsy, and cognitive and behavioral impairment. So all these can affect the quality of life of a baby. It is one of the leading cause of neonatal brain injury and mortality, and the incidence vary from 1 to 3 per thousand live births in developed countries and up to 20 per thousand in developing countries. Now, therapeutic hypothermia. It is a standard of care nowadays for moderate to severe hypoxic ischemic encephalopathy. So essentially what we do here is we are bringing down the baby's temperature to core temperature to 33.5 degrees centigrade and keeping it for almost 72 hours and then slowly rewarming. So this is a neuroprotective strategy for these full-term and near-term babies. So what it does is it modifies the cell's program for apoptosis and thereby decreasing the cell death, and also it decreases the cerebral metabolic rate. So it halts the progress of brain injury which has already happened due to hypoxia, or it stops. Two types are there. One is selective head cooling and other one is whole body cooling. Whole body cooling, here what happens is we cool the whole body down to 33.5 degrees centigrade. It causes more uniform cooling of the brain and the deeper CNS structures. Obviously, it is associated with more adverse effects. Whereas selective head cooling is just cooling the head, where the deeper structures may not be cooled completely to the desired temperature. Now, criteria for therapeutic hypothermia. So, who are the babies who are eligible for therapeutic hypothermia? So, essentially, this one I've taken from CMC Vellore, the criteria which is from CMC Vellore. Basically, it is an Indian modification of NICHT criteria. So the gestational age more than 35 weeks and the birth weight more than 1.8 kilogram babies are fit in for therapeutic hypothermia. In some criteria, you can see gestation 36 weeks or more and more than 2 kilograms. And essentially, the babies have to be less than 6 hours of age. And they have to meet any one of the physiological criteria, that is ABG, arterial blood gas of the umbilical cord, or first postnatal hour should be less than, the pH should be less than 7, or base excess should be more than -12. Apgar score should be less than 5 at 5 minutes, or the ventilation required for at least, or respiratory support is required for at least 10 minutes. And also, they have to meet the neurological criteria, that is, seizures or evidence of moderate to severe encephalopathy. So, for that, you need to meet 3 out of 6 of modified Sarnat and Sarnat criteria. I'm not going into the details of all these things. So, this is for just you to know. Now, some numbers which are very important in therapeutic hypothermia. So, the cooling window period is 6 hours. So, you need to cool the baby start cooling within 6 hours of after birth. So the earlier the better, always. So make a decision, start the cooling early. And we need to cool the baby rapidly down to 33.5 degrees Celsius. That is around 30, within 30 to 90 minutes. The time varies depending on what device you are using. Maintain the core body temperature between 33.2 to 33.8 degrees centigrade for 72 hours. The thing is, the wider fluctuations of temperature should be avoided. And rewarming again is a slow process. You need to rewarm the baby by around 0 0.5 degrees centigrade every hour, and it should be completed within 6 to 10 hours. Now, the type of equipments that are used for cooling. So, there are different types. One is servo controlled cooling devices, which are available in developed countries and some of the higher tertiary, some of the big tertiary centers in India. So these servo controlled cooling devices are costly. That is why it is not that so common in our part of the country. So to name a few, you have blanket roll 2 and 3, criticool, tecotherm, and cool cap, of which the first three are whole body cooling device, and the cool cap is a selective head cooling device. The principle is essentially same as that of our servo controlled warmers. What it does is we need to set a temperature to which the baby has to be cooled into, and then we have to keep the baby on a blanket. So the coolant, it can be the water or alcohol based gel, it circulates in through the blanket and bring down the baby's temperature to the desired level. So that is what it does. The nursing job is relatively less compared to the other two in servo controlled cooling devices. Then the next one is frozen ice gel packs. So these frozen ice gel packs, these are used in setting where we don't have a servo controlled cooling devices or any phase changing materials. So this needs intensive nursing care. That means the nurse has to monitor closely. The temperature needs to be monitored closely. These frozen ice gel packs comes along with certain medicines or vaccines. So these need to be frozen in the refrigerator. And when the baby is ready for therapeutic hypothermia, you need to get 4 or 5 of these, and then keep 2 underneath of the baby, and 2 on the axilla, and 1 maybe of the abdomen. Need to make sure that these things are not come in direct contact with the baby. You need to have a blanket or a thin layer of blanket, so that it should not come in direct contact with the baby. So these frozen ice gel packs, once we have started cooling, rapidly brings the temperature down to the required level, and once the target temperature is reached, you can take one by one to maintain the temperature at that level. And now the third one is the phase changing materials, or PCMs. So these are relatively newer things which are now being used commonly in low cost settings, and it is the one face changing one equipment which uses face changing material is a Miracradle. So that is being used commonly nowadays in our part of the country. So phase changing material, what does it do is it when it changes its phase from solid to liquid or liquid to solid at certain temperature level. So thereby it either absorbs heat or it dissipate heats out. So we'll just go through the Miracradle. So Miracradle is the one which is using phase changing material or PCMs. So Miracradle, it essentially contains a cradle and it uses phase changing materials. So when a baby is to be cooled, you need to place this cradle in the warmer. This fits perfectly in the warmer. So this cradle, you just put it's a plastic material, molded plastic material. So you just keep it in the warmer, and then you can keep the 3FS29 phase changing materials. So that changes temperature, changes its phase at 29 degrees centigrade. So that is why it is FS29. So FS23, FS29 are kept in the cradle, and over that you keep a conduction mattress. Now, and then over the conduction mattress you can keep a blanket so that uh, you can place the baby over the blanket. So, and then you can place a uh, you can place a rectal thermometer or rectal temperature probe into the rectum of the baby. It should be going 3 to 5 centimeter inside the rectum, inside the anal canal, and make sure that you secure it properly by taping it. And then you monitor the temperature for the first 30 minutes, maybe if every 15 minutes. For the first 30 minutes, your target temperature should be reaching less than 34 degrees centigrade. Say if the temperature doesn't come down to 34 degrees centigrade after 30 minutes of starting therapeutic hypothermia, you need to introduce save FS21 between FS29 and the conduction mattress so that the babies are cooled rapidly down to the desired temperature. So once the baby is reached the desired temperature, you can take the FS21 out and then continue with FS29 and the conduction mattress. So that is what essentially Miracradle. This is how Miracradle works. Now the temperature maintenance in Miracradle. It is a rectal temperature that we measure. That is a standard temperature that we look into. That if the temperature goes above 33.8 degrees centigrade, you need to introduce FS21 in between FS29 and the conduction mattress. And once the temperature comes down to less than 33.8 degrees centigrade, you can remove it. And similarly, if the temperature falls to less than 33.2, or if the temperature comes down, you need to make the baby a little warmer. So you need to introduce an extra piece of folded cloth between the newborn and the conduction mattress. And also you can cover the baby. Still, if the temperature is on the lower side, you can switch on the warmer to manual mode and then grade up the temperature 10 to 20% every time and then monitor. And once the target temperature is reached, then you can gradually bring down the warmer temperature and switch it off. Now, some do's and don'ts in Miracradle. So, do not keep FS29 and FS21 in the deep freezer. Always keep it in the lower part of the refrigerator. Avoid direct contact of these PCMs with the newborn. Always keep a layer of blanket. Do not bend, distort, or fold. Once in a month, try to cross check the temperature on the charged FS21 and 29. And for cleaning the surface, soap water solution, isopropyl alcohol, or any other newborn friendly cleaning solution can be used. And always sanitize before and after use. Now, the general nursing care. As any other nursing as any other baby, general nursing care includes the vitals monitoring. So vitals monitoring is very important in this baby because, so what all things you need to monitor? It's the heart rate, blood pressure, saturation, temperature, etc. So heart rate, why heart rate is important? So when you cool the baby, the temperature comes down to somewhere around 80 to 100 beats per minute. So that will be the normal temperature for at that temperature. Any change in temperature will change the heart rate. So any one, say 1 degree change in temperature will change the heart rate by 15 beats per minute. Say if the temperature comes down, say to 80, then 70 to 60s, then it should raise an alarm, because sometimes it can be any pathological arrhythmias. So always get an ECG. Alert the physician. Get an ECG done if it comes down less than 70 beats per minute or so, and make sure that it is sinus arrhythmia, sinus bradycardia. And similarly, if the temperature, if the heart rate goes above, say 110, 120, when the baby is cooled, that is again not normal. That indicates that baby is having tachycardia. For a normal baby, 120 is normal, but for the cooling baby, 120 may be abnormal, 120 or more may be abnormal, 110, 120 plus may be abnormal, because that indicates maybe an underlying sepsis or agitation or pain or such conditions. So that also needs to be addressed. Then maintain the blood pressure to the normal range, because cerebral auto regulation will be impaired in these babies. Temperature, we have already discussed. Rectal probe should be inserted 3 to 5 centimeter, and alarm limits should be set between 33.2 degrees Celsius to 33.8 degrees Celsius during cooling. And you need to check the rectal probe hourly and also monitor skin temperature regularly. The rectal probe should be checked, especially for because it comes out with the meconium. So always check it, and it is dangerous, especially in babies who are on servo-controlled uh, therapeutic hypothermia, because that will sense the NICU temperature and then start overheating the baby, which is again dangerous to the brain. Now, frequency of monitoring. Uh, the frequency, it should, that like heart rate, the respiratory rate, blood pressure, and saturation should be monitored every hourly. And the rectal temperature, it should be monitored every 15 minutes for the first 4 hours, and then every hourly. Skin temperature again should be monitored hourly. Neurological examination should be done prior to cooling and every 24 hours till the baby is normal or discharged. And urine output should be monitored 6 hourly, and skin breakdown and redness should be monitored every 4 hourly. Now you need to secure venous access, that is central lines and peripheral cannulas at an early stage, because once this therapeutic hypothermia is started, the circulation will be sluggish at the periphery, so it will be difficult to site cannulas. So get the central lines, cannulas, and peripheral arterial line if required. Infection control is another big important for these babies under hypothermia, because hypothermia, as you all know, is a state of immunosuppression, and they are prone for sepsis. So you can start on prophylactic antibiotics. You have to have proper care of central lines and indwelling catheters, and you need to daily review an evidence of infection. Blood investigation should be done as per unit protocol. So main investigations include arterial blood gas, electrolytes, LFT, glucose, coagulation profile, and complete blood count. To fluids and feeds, there should be fluid restriction. You need to restrict the fluid to somewhere around 40 to 60 ml per kg per day, and because otherwise it will result in cerebral edema, and sometimes if there is acute renal failure, that can adversely affect the fluid fluid balance. Then minimal enteral nutrition. If the baby is hemodynamically stable, you can always start on minimal enteral nutrition. It again varies from unit to unit. Some unit prefer to keep it at keep the baby NPO till it is over. And if the baby is hemodynamically stable, you can start minimal enteral nutrition as well, maybe 10 to 15 ml per kg per day. And pain scoring should be implemented routinely in these babies because we are cooling the baby down. And if the baby is agitated and is having pain, that will adversely affect the outcome of therapeutic hypothermia. That will increase the cerebral metabolic rate and can adversely affect the outcome. So sedation also can be considered. Can be the morphine or fentanyl, the low dose can be considered. uh, it varies from unit to unit. And the most important one is developmental supportive care, which is, I should say, it's a very important part of the care of these babies. So you need to have a quiet environment. That is, you need to switch off the lights and switch off the alarms or set the alarm limits and always attend the alarms at early so that you keep the sounds to a minimum. And you have to do the care. It means you have to have a bundled care approach. That means do all the cares at a time. Like if you putting a cannulas, or if you are taking blood samples, changing the nappies, and putting an NG tube, all these things, or changing the position, all these things you can do at a time, so that in a coordinated way, so that the babies are undisturbed for a few hours. And then the third one is a family centered care. You need to involve the family, the parents. So you need to have a bond with the families, the parents especially. You need to talk to them. You need to tell them about the babies, and you need to explain what is happening with the baby. You need to tell them that what are the wires that are going in and out of the baby. All these things needs to be explained so that their apprehension is minimum. And you need to have a good communication skill for that. And you should know about therapeutic, some basics of therapeutic hypothermia as well, to talk to them. Now, care specific to cooling babies, that is skin care, that is frequent inspection and repositioning of these babies are important because cold injuries are very common. They can be nursed in supine or either 30-degree tilt to either side. Monitor for skin color, perfusion, skin breaks, and subcutaneous fat necrosis, especially at bony points. You need to have a close neurological observation to look for evidence of seizures, and you need to have an ongoing neurological evaluation to look for any worsening of encephalopathy. Also, you need to know how to interpret amplitude integrated EEG so that the physician can be alerted at a very early stage for those units where they have an amplitude integrated EEG. The staff should know how to interpret it. Need to maintain the blood pressure, temperature, carbon dioxide, saturation. Any change in these, and the glucose, any change in these can alter or exacerbate the brain injury, which has already got a hypoxic injury. So this is just a table depicting the importance of vitals and their and the problems associated with the alteration in the vitals. So I'm not going into the in going through the details. So you just can have a look. So in a nutshell, a nurse who is caring for a baby who is undergoing therapeutic hypothermia should learn to recognize neurological signs and symptoms that are relevant to that baby. They should be able to interpret the amplitude integrated EEG so that the physician can be alerted at the first sign of clinical or electrographic seizure or worsening of encephalopathy. They can optimize the care quickly by setting up a cooling blanket and EEG machine so that the treatment can be initiated very early, which is very important as well. They need to adhere to the management guidelines and anticipates the next step in care. So the local unit protocol should be thorough for the staff who are caring for these babies, so that they know what to do next before the physician intervenes. Need to have an effective communication with the families, and last but not the least, need to have a proper documentation of records, which can be used later for research purposes as well. So, thank you for your patient listening. We can have a discussion at the end of this session through Telegram. Thank you all.